Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and Speech Therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to SLP Learning Series, a podcast series presented by SpeechTherapyPD.com. The SLP Learning Series explores various topics of speech-language pathology. Each season dives deeper into a topic with a different host and guests who are leaders in the field. Some topics include stuttering, AAC, sports concussion, teletherapy, ethics, and more. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. Now, come along with us as we look closer into the many topics of speech-language pathology.
Hello, everyone. Welcome to the podcast mini-series, Culturally Speeching, presented by SpeechTherapyPD.com. Thank you for joining us for our fourth episode, Cultural Humility Through Inclusivity. By the end of this course, my hope is that you will be able to identify the key principles of cultural humility and their role in promoting inclusivity within our clinical practice. Also, that you'll be able to recognize common barriers to inclusivity in speech language pathology and how cultural humility can help address some of these challenges. And then finally, I hope that you'll be able to walk away with some actionable strategies that you can implement to foster a more inclusive environment that respects and values diverse cultural backgrounds as you practice. As always, this episode is offered for 0.1 ASHA CEUs, and I am your host, Dr. Treasure Williams-Wood. I am a speech language pathologist and clinical research consultant. I am in private practice in Chicago, Illinois. Before we get started, I have a few items to mention. First of all, we love and encourage questions from our participants. So please, I always love to see where folks are from. I'm always going to check the chat. So drop in the chat where you're joining from. I've had nights where I've had a lot of folks on the West Coast, California-ish, and then sometimes we have evenings where we have a lot of people from Midwest or South. So I kind of want to see who's representing strong this evening. So go ahead and throw in the chat where you're from. Southern California, oh, New Jersey, New York. Oh, is this my friend or is it, I see, okay, cool. Buffalo, Long Island. That was my attempt at a Long Island accent. That wasn't really good. Oh, you grew up in Chicago, not from Bloomington. Love it, love it, love it. Cool. Keep telling me where you're from. Orange County, just beautiful weather out there. So you can put your questions in the chat box for our guests to answer throughout the episode. And we are really informal around here. Everybody is either finishing up work or just got out of work. So this is very organic in how our discussion is going to unfold. So please throw that in there. Also, as a reminder, if your state license requires live CEUs, be sure to complete all course modules, including the one that says complete course, before the end of today on your SpeechTherapyPD.com account, okay? So here are the financial and non-financial disclosures. I am the host of this podcast and receive compensation from SpeechTherapyPD.com. And I am a salaried employee of lingraphica.com and the CEO of Willwood Consulting Services PLLC. My 9 financial disclosures are that I serve as member at large in speech language pathology on the American Speech and Hearing Association ASHA Board of Directors. And now here's a little bit about our guest today, Miss Lillian Thompson Brown. I'm going to invite Lillian to turn her camera on so you can just see how fabulous she looks. Who looks like that at the end of the day? I don't. Lillian Thompson Brown is a speech language pathologist and a PhD student in Northwestern University's Communication Sciences and Disorders program. Woo, go Wildcats. At Northwestern University, Lillian is a member of the Early Intervention Research Group Lab, led by Dr. Megan Roberts. Lillian graduated with a Bachelor's of Science in CSD from the University of Central Florida, UCF, and received her Master's of Science in Speech Language Pathology from Howard University. Driven by personal experiences as the younger sibling of an autistic brother, she has dedicated her time to volunteering and holding leadership positions in local and regional autism advocacy boards. She is the former chair of the Chicagoland chapter of Autism Speaks Young Professionals and has helped to create autism sibling support programs in Florida and Maryland. With over a decade of experience as an SLP in diverse settings, Lillian is committed to increasing equity within the research and practice of speech language pathology. As a PhD student, Lillian's research interests include improving autism diagnostic experiences for Black caregivers, increasing timely and accurate diagnoses for Black autistic toddlers, and the implementation of culturally responsive strategies in autism assessment and intervention. And so, with that being said, please join me in giving the warmest welcome to Lillian Thompson Brown. Thank you so much for being here.
Thank you for having me. It is my pleasure. My pleasure. So excited to be here.
You, like I said, I always feel like reading, it's just amazing reading someone's bio. I've always appreciated you for everything you are, but reading your bio, made me think again, like, man, she really is that deal. So I'm excited to
Thank
hear
you.
your thoughts and learn again from you. And I think I always like to start off, this journey that we do every month, talking about definitions. How do we define things? I think that in a world where everybody just kind of whips up DEI and we have these terms but sometimes we don't really know what they mean. And so I would love to know from you, how how does cultural humility, in your opinion, contribute to fostering inclusivity in our clinical practice as SLPs?
That's a great question. So I see, first of all, let's just talk about what inclusion is. We hear about inclusion like, okay, well, it's part of the DEI. We have the diversity, the equity, and we kind of understand what diversity is, equity. Okay, but what do we mean by inclusion? And it's really, how can we help our clients and our students thrive in their environment? And what the biggest part of that is the equity component. And so I see cultural humility as the vehicle to getting inclusivity. So if we are going to understand how a student can maybe thrive in the classroom, we have to understand what is best from their perspective. From I can't use how I communicate necessarily. I may need to understand how that person communicates and what communication styles they're used to and what type of learning that they're used to and whatnot. And so the cultural humility is really the vehicle to get to the inclusion with keeping in mind equity, that equity is important, that it's not about equality, it's about how to help meet people where they are and support them as they need.
I love that. Thank you for that. And, last month we talked with Dr. Valerie Borum about two things about diversity and equity. And she gave us some really interesting insights on how when you are in a environment or when you are in systems like many, I'm sure, autistic children are that you work with and many of our patients are where the system is standardized on whiteness or
Yeah.
the system is standardized on a white experience, or the system is standardized on a able-bodied experience, or the system is standardized on an experience that is not of the person that we are serving, how that sets the foundation for inequity and exclusion. And so my question to you, I wonder, what are the key differences between cultural humility and cultural competence when we talk about promoting inclusion and inclusivity?
Yeah, I think that, well, when we talk about cultural competence, it implies that I know it. I'm confident in it. I got this. And so even though I am the little sister to an autistic brother, I've grown up, my household, I has always involved a person that we love so much that's autistic. I don't know what it's like to be an autistic person, a Black autistic person. And so humility tells me that I need to learn more. I need to understand more. So cultural humility is about wanting to know more and constantly evolving and realizing, okay, let's see, like, what else can I know? Like, this is a unique experience. Let me learn more about this. It's acknowledging that we don't have all of the answers. And when we think about what we call discrit, the intersection of disability studies and critical race theory that Dr. Subina Adama created with her collaborators,
Yeah.
it's about understanding lived experiences, listening to the voices of those with lived experiences. And so, the entire mantra is nothing about us without us. And so when we think about culturally about inclusive practices, when we're in clinical settings, it's understanding what was this like. Let's listen to self-advocates. Was that experience traumatic for them? Like, what made that traumatic, and why, and how can we help to maybe mitigate that, and how can we, and what do we need to adjust for this, and not just, okay, I listen to an autistic person. Okay, I listen. There are Black autistic people. There are autistic people of
Yeah.
all different races, creeds, and colors. Like, let's get diverse perspectives so that we can better understand. So I think that the biggest difference is with the cultural humility and the cultural competence is really understanding that this is something evolving and that I need to learn more and I need to listen to different voices as I go throughout my practice.
Oh my gosh. So I just typed this in the chat because I don't want to lose it. I think my takeaway is going to be nothing about us without us. Oh my goodness, that is so good, right? Because
Yeah,
especially in research and in clinical practice, we say, okay, well, we went to school, we're the experts. And the truth is, cultural humility, like you said, really what I'm taking from what you said is that we're never going to be an expert on somebody else's lived experience. They are the
no,
expert on their lived experience. And we have to
absolutely.
constantly humble ourselves and decenter ourselves while also holding space and commitment to do the work. And I think for a speech language pathologist, sometimes that can be really challenging, where if we're not centering ourselves as the experts, and then if we say, oh, well, I don't know, we kind of throw up our hands, and then we either check out and don't make a commitment to learning if we're not in the middle of it. But we have to be able to do both. We have to be able to
Right.
decenter ourselves from a person's, the expertise as the expert, but then also say, and I'm going to continue to engage critically with you so that I can get some of this knowledge while also practicing. I'm not going to say, oh, well, I'm not perfect yet. I don't know everything. I'm not that big on culturally responsive practice, so I can't really lean in. No, I'm going to decenter myself while also making sure that I'm engaging critically with this person's lived experience and reflecting on maybe some ways that I could be potentially causing harm, or that I could
Exactly.
be potentially having some blind spots. So that's
And the
all.
and the practices that, as now that I'm more on the research side, seeing how biased research is, particularly in our field, and who these interventions were standardized on. Who was the idea, who is it for and by? Especially when we think about autism, we think about this stereotypical face of autism, which was typically a little white boy And so that everybody else around, it kind of got overlooked. But when we think about like who, and when we think about autism, we think about social communication. Can social communication not be impacted by culture? How can it not be impacted by culture? So when we're doing these interventions, okay, yes, these are standardized. That's great. Who are they standardized on? Okay, fine. Okay, and what are we promoting? So having that flexibility is really key, in practice.
Thank you. So, I'd love to hear more about that. And I'm also going to be checking the chat just in case anyone, if you have questions for Lillian, please throw those in. So, can you share some examples of how you've seen this show up in your research, right? You're in this lab of of a lack of inclusivity, or and then maybe hopefully if you've seen any examples that really show inclusivity, it's what not to do and what to do. Can you share that with us?
Yes, absolutely. I think, there are definitely in research, there was a study that I believe Steinbrenner that where they looked at the past autism intervention research over the past 20 years. And the 60%, first of all, 80% didn't even report anything about race or ethnicity. And so, okay, well, why aren't you reporting anything about race or ethnicity of the participants? Okay, that tells me something right there. And then the 20% that they reported on, of course, 60% are white. There is a small, like 8%, a small percentage that are black or people of color. And so you are seeing that, okay, there's a reason they're hiding this information. And so, like, how can we create inclusivity if this is not being researched, if we're not even taking these other people into account?
Yeah.
And then on a positive note, when I in clinical, in just practice, my last full-time position as an SLP was in the school system, and I was at a school with predominantly Arabic speaking children. And so I went into the classroom, and one little girl, she was about 6. This is my third time seeing her, and she looks at me, and I say, "Hey, nice to see you today." And she says, "What's that brown on your face?" And I was like, "Oh my gosh, wait." I'm like, "Is there chocolate?" And it was like,
Right.
something, what the heck? And then it dawned on me, like, she meant my skin color. I was
Yeah.
like, "Oh, she's not used to see." I said, "Oh, I'm black." And then the little boy next to her was like, "Yes, blackface." I'm like, "No,
Don't ever do that.
not blackface. That's not blackface." I'm like, "Okay, so we gotta let's
Yeah.
scale this back to understand." But I had to understand, like, they're not used to seeing people that look like me. The people, and so when we're in, when I'm pulling materials, when I'm making an AAC device, things like that, I have to take into account that some things may not be culturally appropriate, or may be foreign to these children, these students. And so, how can I best adapt this? Maybe if their teacher is always wearing a hijab, then maybe the teacher doesn't look like this blonde-haired lady with a flip at the
Icon that's
end,
on the AAC
that
side.
I'm seeing.
Yeah.
So, okay, if this child is not using this, maybe I need to think about how I'm presenting it, the materials that I'm using, thinking about those materials. And so
It's a
those
very,
are
what
the
a
good and the bad.
salient example. And I'm interested too. Throw in the chat what setting you're in. I'd love if do we have, like I said, we always have a mixed bag, which is also great.
Yeah.
Interested to see tonight, do we have a lot of folks who are in schools? Do we have folks that are in healthcare settings? Do we have folks that are in private practice, early intervention? Interested to see where everyone is coming from. And so though that's such a great example. Okay, we got some birth to three, early intervention.
Yeah.
Okay, yeah, we got a couple EI.
Okay, EI.
Oh, cool. Intermediate school. Does intermediate school mean middle school? I'm from the Midwest. So I think that means, I think intermediate is like our version of middle school, right? 6th, 7th, 8th grade, I think. Outpatient, early intervention, K through 8, elementary public school service, and low socioeconomic status community. Okay, K through 8. Cool, cool, cool. And so I would love to kind of talk more. You kind of shared some of these things in terms of clinical research. And I think the thing that you said that really stuck out to me, Lillian, that people don't realize is that when it starts at the research level, I think in our minds, we're like, oh, there's research and then there's practice. But when you, like you said, when we set a file, but they're always intermingling with each other. So when you standardize something in research based on this one type, this one archetype of a person. And that research then becomes the standard for clinical practice throughout every school and setting that we are seeing in this chat, right? That's when you start seeing this lack of person-centered care and the lack of inclusion. So what are some common barriers to inclusivity in speech language pathology that you have witnessed? And I would love to hear this from 2 points, because I think it's so valuable to hear as a person who is a sibling of someone with autism. And then I'll ask, as a practitioner, but just as a sibling, what are some things that you have found that have been barriers to inclusivity in speech pathology?
Honestly, it's for both. Both of my
I know you can't really separate who
it,
you are, but
it
yeah.
really no, because it's the same thing. Like I deal with the same thing. It's a lot of it is lack of support, in terms of funding, in terms of support personnel to implement certain things. I think a barrier is if you don't, you say, okay, this person, can be in this environment, but oh well, we don't have enough staff right now, and oh
Right,
well, we have to pull this person in the middle of the day. It's like, okay, well then are we really helping this person thrive? And so
right.
seeing that is very frustrating. It's quite frustrating. And it's like when you're as a family member trying to do your best to, how can we help, how can we facilitate this in these different settings, if there is a lack of resources or if there is a lack of access. And then representation in the field. I think that is a huge barrier. Representation in terms of the techniques like we talked about, but like also the clinicians, who's providing this, who can. It's hard to see the perspective that you don't know about if you're not trying to learn more.
Right.
So if you don't understand that this is a complex, unique position to be at the intersection of race and disability, then, and you're not trying to learn, and you're just trying to do, okay, well, this is what I do with all my kids, this is how I do it, and this is the lesson that we're going to learn today. Then, it's decreasing that person's ability to integrate within their environment, because
Mhm.
you're promoting what you know and what you see, and and there's rigidity that may prevent success for from their perspective.
Rigidity
um
in speech pathology? What? Not us. Not us.
yeah,
Not
right,
us. But
like
yeah, but that, so many aspects of what you just said are so true, because as you're talking about what we do in our practice, and I like to look at this from all different types of angles, which is why I love that we're doing this is a 7 episode series. So it's not just the ABCs of DEI, really getting deep. I also look at how we do this in practice because we were taught how to do this, but then we also do this to each other and as
yes,
professionals. And, I cannot tell you how many times, everywhere I go, when I talk to speech language pathologists and they talk about imposter syndrome and they
yeah,
talk about not feeling included, about feeling like they don't belong, about feeling
right,
like they're on the outside looking in. And so to me, as you're speaking about this, in parallel, I'm thinking about how not only are we kind of acting this out just by design, because this is how we were kind of trained. Again, we were given a normative standard, and
yeah,
we've all been taught to practice in a way that's like, okay, well, look at developmental milestones, look at what they should be doing, and then have this kind of deficit model mindset that we're slowly trying to get away from. But then we also do that in the way that we prepare practitioners, right?
exactly.
We
And who the practitioners are
and who the
in
practitioners
our
get to
field.
be.
Are we supporting our student clinicians, our graduate students that have disabilities?
Right. And I
How are
can,
we supporting them?
yeah,
Are we recruiting? How can we learn, like, where's the recruitment?
exactly.
They say, well, they know the field, they should know the field exists. I don't know. No, let's do some
Yeah.
active
And then
recruitment. We
even
need
when
those
we,
voices.
yeah, and even when we do recruit them in terms of retaining them, just the huge juxtaposition of being in a profession where we encourage, we're supposed to be the beacons of inclusivity for our clients, and everyone communicates differently, until you want to be a speech pathologist.
Exactly.
Then the way that we criticize each other and critique each other, the gatekeeping that we do for people of color who are entering the field, for people who are differently abled who are trying to enter the field, and that they have to go together, because
Exactly.
there's a saying, you can't be what you can't see. And so
Exactly.
how can you develop your identity as a speech language pathologist? And everyone has their own unique identity as a clinician. When you walk into a classroom, a professional setting, and you don't see yourself, you don't
Yes.
see yourself
Or
in
you're
anything,
and you're not supported, or
and
you're
you're not
there and you're not
supported.
supported.
That's
Because
probably one of the,
again,
yep,
even if you see somebody that may look like you, if I'm a person that is neurodivergent, or if I'm a person that has a physical disability, I might still feel isolated. This is a unique perspective. It's not just having that shared cultural, it's also recognizing that there's a unique experience being in those intersections, just like we all have intersecting identities.
yep.
And so, when you have, but if people are acting like it's a burden to do, well, I got to have the accommodations in class, and
Right,
I don't
go
want
get
teachers
your
rolling their eyes.
convocations, tell them all of that. Okay, well, it's so right, and I've thought about this many times, and because I was formerly a director of clinical education at a graduate program. I've taught at the graduate level for years. I have been a supervisor in clinic, and and then also working, right, and going to these big volunteering and going to these conventions, and I had an epiphany when I was at a big convention. It might have even been the ASHA convention or maybe my state convention. And I saw how, we go from room to room, and we sit in these rooms and we watch these PowerPoints. And we've been doing this way of learning and conveying information to each other this same way for 50, 100 years, right? And I think, man, if we were teaching students with autism, if we were teaching young kiddos, we would not be expecting them to just sit down and watch
Right.
us look at a PowerPoint for 2 hours. But when we're
Yeah.
having conferences, and when we're in the classroom at the graduate, undergrad, graduate, and doctorate level, we're still expecting that of each other. And I think,
That's right.
I love the conferences, but a lot of times I don't go to, I can't even sit anymore. I just
That's
physically
right.
cannot even sit, because the learning is just so not tailored to me. So how can we, if we're still being taught with these kind of outdated and really not current practices based on learning and, you know, inclusive learning, how can we like turn that part of ourselves off, and we go, okay, I'm going to get so creative when I go teach all these people, and I'm going to do all these things when I work with my students and when I work with these kiddos. And then when I go back to the conference, or when I go to class, teach a class, we going right back to this PowerPoint. We're just going to read from these slides.
Right.
And it's like, now that's the same brain. It's the same brain. So I think
Yeah.
that's really powerful what you said.
But that's why I think that the diversity aspect is so important. Having people from different cultures and how they express and how they communicate, and seeing different communication styles, like say, oh, I never thought about that. Like, let's break outside the box. It doesn't have to be this way. Like, but I don't know, like, if I'm just going, well, I'm doing what they told me to do, and this is how we do it. No, like, let's expand, reach in. We all have a culture. Reach in and try to find,
Yeah.
what we can go. And we're also trying to adapt it to who we're servicing.
Absolutely. So
Adaptability.
how adaptability, key word. So how do unconscious bias and, preconceived notions, in your opinion, affect inclusivity in clinical settings?
Yeah. I think that it says a lot when we think about, and I think that's also what helped to birth the discredit movement, is that there were these biases that were coming about in terms of who gets to be labeled and what they get to be labeled as. Who
Mm.
is seen as more of a behavioral problem? Black and brown students are more often
Oh, tell me
seen
more
as a
about that.
behavioral problem versus, and so it's like, oh well, or they have an attitude, or this person is just defiant, versus this person has like focused interest that they're really interested in. We having these stereotypes and these unconscious biases, or even as clinicians, we're doing a classroom observation, how we're looking at these interactions. If, or those of us that are, in early intervention, we're looking at these parent-child interactions, saying, oh my goodness, that parent is really harsh in how they're talking to the child, or they seem cold. All of these things are, why do you think that they seem cold? Is this how, or this might just be how they're interacting because of a cultural, how this is culturally bound. Like, you having to recognizing the things that we're doing when we're identifying these students and clients and patients, and what that means. I have a couple of examples. So clinically, even working in a nursing home, I saw so many people where, they're asking me to, see them for memory. There's some issues with memory there. Let's see, do a cognitive exam. And then I'm talking to them and I'm like, this person is very clearly autistic. There's cognition is not really a problem. And then, but this is an older Black woman.
So it was
they did, oh, she's got a diagnosis of schizophrenia. And it's like, wait a minute. There's something else going on here that I think we need to realize. Why has this not been identified? And how am I'm not going to, obviously I'm not the doctor. So, but this is something that I need to advocate for and bring this into attention so that I can best support this person.
Right.
And then on the other side, in the school system, I had a friend who works in the school system tell me that, she had this teenager. He was about 15 years old, and she was a Black male, and she was pretty positive that he was autistic. But the psychologist, who was a white male, did not want to give the child an evaluation because, well, they're Black and the parents probably don't want labels, so we don't want to burden them with anything else. So we're not going to evaluate.
What an assumption.
And so you've taken maybe what somebody might have said to you once in the past, and you've now said that, oh, this must be what all of the Black people think, or this must be what all of the Indian people think. And it's like, that's not appropriate. These are these biases that you have, that you're making these decisions and you're not realizing at times where they're coming from. That's why cultural humility is about this ongoing process of, when I make a decision, okay, what I need to do, that self-reflection. Why do I think this? Where am I getting this from? Right. How might this be different? How could this be different? And if so, let me talk to this person. Let me get to understanding, to making sure that I'm understanding what I'm seeing, or I'm communicating in a way that they're understanding. Yeah, I think the unconscious bias is definitely it's going to impact how we create the environment that people can thrive in, creating the environment where people feel supported. If I just assume that, again, even in going back to the graduate students, well, they're here, so there must be okay. And it's like, or oh, they have that disability.
Yeah, and you're like,
we're
what
going
is okay
to label
meaning?
them.
Yeah, what does okay
exactly.
mean? Okay mean that they're able to learn according to, how we've been doing it for the past 100 years.
Exactly.
Wow. And you actually answered my follow-up question, was what strategies can clinicians use to identify and address these barriers? And you talked about just the importance of self-reflection.
Absolutely.
I am going to put in the chat, I'm going to share this website, That's Unheard Of, where you're actually, I love this. There's a couple of websites that I love that I'm going to share. That's Unheard Of is really awesome. It is a whole website. It's actually completely put together and sponsored by ASHA, and it includes self-assessments that you can do in the comfort of your own home to just learn more about your cultural IQ, where your team stands, are you videos on like how cultural impacts care delivery? It's just this wonderful information hub. So I definitely recommend that everyone check it out. There's also this section in there called Check Yourself. And then you can click like get your tools, and it there's one that's a place in there called Intersections Activating Allyship. And it actually gives you scripts and practices, scenarios that you can use to practice speaking up and not calling people out, right? Calling people in, right? And so I hear so many people, in our profession where they know something is like, oh my gosh, like that scenario, right? I'm sure anyone listening that heard that scenario probably would have been in that situation like, okay, that is so outlandish. But then it's that extra step of, what am I supposed to do? Like, I can't be like, no, sir, that's just racist, right? Because that, there's a whole different set of social things that you have to deal with. And so really trying to figure out how to activate your allyship and call people in and understand to try to have these discussions and be leaders in this. And so there are like scenario cards on this website where like a scenario like that would be shared and it would help you practice, and all factoid cards and everything. So I encourage everyone to check that out. Another website that I'm going to throw in the chat is the Harvard Bias Test, my favorite. I take it probably more than I should, but it's actually called the Harvard Implicit Bias Association Test. Absolutely love this. I recommend that anybody, but especially as practitioners, that we are regularly checking our own biases. So like you said, when you talk about using strategies in terms of self-reflection, these are good tools to help you self-reflect. With this, they have, it's got to be at least, let me count. It's got to be at least like 10 different things on here. So there's like, you can take a test for Asian American bias, president, skin tone, disability. I highly recommend it. So it helps you, weigh, do you have a subconscious bias leaning more towards physically disabled or physically able people? There's one for religion, there's one for weight, there's one for Asian Americans, Hispanic Americans, Jewish Americans. There's one for sexuality, age, gender and career, transgender, race, Arab, Muslim, and Native American. And so I definitely, if you want to try to some of those strategies for self-reflection that Lillian shared, I recommend some of that for you. So thank you so much for that. My next question is really about, in terms of practical steps. And, we talked about integrating self-reflection, but in terms of our daily practice, besides self-reflection, if we're going to look at what types of self-reflection, what does that look like? Like on a day, I would love for you to use yourself as an example. So let's talk about an average day in your practice, right? How do you apply self-reflection throughout your day as a speech language pathologist to enhance inclusivity?
Yeah, that's a great question. I think a story comes to mind. Because I'm on the advocacy and I'm like, yeah, we're dismantling racist and ableist systems.
Yeah,
I remember thinking about, a family that came in and they really were wanting their child to talk. It was all about, okay, the child is talking. Now the child is communicating in all different kinds of ways, using all of this nonverbal communication. They're non-speaking, but they're using their hands and gestures and pointing and all sorts of things. But the parents were like, I really want this child to talk. Like, I want them to talk. And they were a Black family. And as a Black woman, I'm like, what's up with that? And I really had to check myself, because I'm also I realized, like, wait a minute, who can afford, like, if their son grows up and is pulled over by the cops, are they going to have time to pull out this AAC device and say, oh, please don't shoot me, oh God, please don't do this? Are they going to maybe there may be another reason behind why they're thinking this way,
right. The
why
fear as
this
a
is what is
parent.
priority. And so, yeah, oh, okay, I can tell them, well, they are communicating, and they are. However, I need to be empathetic to their perspective and the environment that this child may be in, where it may necessitate that there are other ways to communicate, or why this might be a priority for this family.
Right.
And that was something that, and again, that I have to, we're constantly learning and trying to better understand how to support people in their environments so that they can thrive. And we talk a lot in therapy, speech therapy, particularly in medical, about quality of life, improving the quality of life. But it's like, what does that really mean?
Right.
And how are we assessing that? Are we talking with the people? Are we talking with the families? Are we understanding what their priorities are and how we can help them reach their goals without placing judgment or promoting necessarily what we feel? And also recognizing, also as a clinician, recognizing that different cultures have different ideas of what disabilities are. What is a disability?
Right.
And so understanding that and not pushing and listening and learning and trying to, not saying that, well, we're going to withhold information. No, I'm going to tell you, these are the things that I'm seeing. Tell me about, how this might work with you. Tell me about how this may work in your family. Tell me how this may work in your daily life. Trying to have that understanding and that relationship to grow.
That's so helpful. And I think you raised some really interesting points that resonated with me. One of them is that understanding that what may be something that it's like okay for you could be a life or death situation in the eyes of someone else, in the eyes of a parent. I am not a parent, and so I can only empathize and imagine what it might feel like to dream and, want to have a child and then have a child and then have this vision in your mind of how raising that child is going to be, and then that's not what you get. And that's not what it's playing out to be, the grieving process that goes along with that. And then culturally, what that means for your life, what that means in your social circle. I've known many folks who are of different cultures who, for them, having an autistic child means that, oh my God, our family is like a failure, that we did, that's just the subconscious undercurrent of it. And so they won't, or they feel like if we acknowledge that this exists in any way, then we are just completely giving into it. We're completely just, accepting it. We're not believing in them, all of these things. And then on the other hand, there are people who are like, nah, this isn't really a disability. Like, so what? They like to stim a little bit, whatever. So what? They like to run around a little bit. And that's not a problem for them. And I think another thing you said earlier that really resonated with me is that, we're really focused on autistic children, but as we're getting more acculturated to how everyone's living, like these kids grow up, like autistic people
Exactly.
They didn't just like manifest and just like start being born and they just like stop, and like they grow old. And so
my brother is 43
that,
years old and is still actually autistic. So there's
yeah, like they grow old. They might be in a
amazing.
nursing home. They might be, and especially with the way society is that we're recognized. We're just waking up to like, oh, a lot of these people are autistic, neurodivergent. We're waking up to it, but there are people in their 60s, 70s, and 80s who are in nursing homes, and they were failed. The speech pathologist failed them, or they were in receiving these services and still went through life, and now they're right back receiving the services and we're still not getting it. And that was, when you said that, I thought, yeah, right, that's right. Like they don't just like dissipate into like a vapor.
No.
They turn 50, right? They're going to age. They're going to age along the continuum of care just like the rest of us do, and we have to be able to hold space for that. Let me go
and
to
advocate, like, even like they've got, the Chicago White Sox were really great at having, especially in April, and so they had a quiet room for people that have,
They
like,
do?
yeah, they
Oh,
had, it was really nice. And it's like, great, this is wonderful. Like, this is something that we need to have. We need to have it year
yeah.
round, especially, and, but also it doesn't necessarily only have to have bubbles in it and toys, like
Right, right.
so there are adults that or might be at
Yeah.
a baseball game that need it, but kudos to them for at least thinking about having a quiet room. We're in these nursing homes or these places where people are screaming and yelling and there's a
And they're
siren noise
still
going
trying to
off and
make
we're trying.
everybody play bingo, and they're still
And then,
trying to
right, and you're
yeah.
wondering why somebody's getting agitated. There's too many things going on right now for this person.
Right.
Like, let's help. How can we again, inclusion is not just placing everybody in the same place and saying, all right, great job, everybody's here. It's okay, this person is not, how can I support this person? What is going on? Like, this person seems uncomfortable. What can I do to make this person more comfortable? Or they're not be able to communicate like they would, it seems like they would like to. How can I help to facilitate the communication
Right.
in their way? Yeah.
Because how many, how many 70, 80, 90-year-olds, you're not going to find any 70, 80, and 90-year-olds with a working definition of autism unless they are severe, what they would label back in the day, severely autistic, right? But the folks now who are autistic and, are able to, the people that can hold jobs and raise families. And when they age 70, 80, 90, they've fallen through the cracks. And so they're sitting
Yeah.
in these nursing, and I'm a former SNF therapist. So I'm thinking of this, like, how, if you have spent your whole life, masking or just kind of getting
Exactly.
through, and then you get taken out of your home environment because you can no longer live alone. And now you're in this environment where, all of these things are just not set up for your brain to be successful at all, and the decline that happens. And then everyone's like, you're getting dementia. Let's just kind of lump it
Yeah.
all with that. But that very real lack of an inclusive environment and that impact.
Yeah.
Wow. And
And
so
I think also another step is when is collaboration. We talked about talking with the families and understanding communities and really and understanding strength-based language, understanding how to talk about
tell
disability.
me more about that.
When we talk about autism, particularly, that's always going to be what comes to the front of
Yeah,
my
no,
mind.
that's great.
But when we talk about autism, moving away from suffering, where there's suffering, or these are the symptoms. We're talking about characteristics of autism. We are identifying these characteristics, and we're moving away from high functioning and low functioning, high support. Everyone has different support at different times. Just because somebody would maybe previously have been labeled as having low support needs doesn't mean that they don't have needs. This is how we support this person. These are the things that may support this other person. And so really trying to understand how to talk about that's why this is also ongoing, because the language, the person first language versus identity first,
Yeah.
moving back and forth from that, it has evolved. And as we listen to some self-advocates say, hey, I'm autistic, and that's great, I'm
That's what I
neurodivergent,
want you to
thank
call
goodness.
me. That's what I want you to
And
call me.
exactly. And so and when we think about it, when I think about it as, I am proud to be a Black woman. I am a
Right.
Black woman. That is my identity. And so I don't have, like, if you say, oh, well, that Black girl, well, no, wait, that's different from having that sense of self that I am proud to be a Black woman, and just saying, oh, well, and just assuming that
That
I'm just
woman
like
who was
everybody
Black, if
else.
someone kept saying, so if you happen to be a woman who is Black, I'd be like, no, I am a Black woman. Right. Like, I'm
Exactly,
not a woman who is Black,
exactly.
I'm a Black woman,
Exactly.
and
I'm autistic. This is who I am. This is how they're saying. But then also there are people that are like, no, I'm just Jane. That's just my name, and that's who I am. And
yeah.
I'm also I'm on the spectrum. Like, these are the things that but understanding, like, just as we are asking people, how do you identify, how would you like to be called, what pronouns do you use, what language would you like me to refer to you as,
Right.
understanding that obviously, with the children, it's mainly what the parents maybe feel comfortable with, but also educating, also letting the not educating, but the family on what self advocates are also reporting, on what feels comfortable for them as they age and as they grow older, and letting them make that decision as well.
Oh, you know what? You just hit on something really powerful that I was talking about with a parent, they were sharing with me, when do we tell our child that they're autistic? We have a child, they're, I don't know, 10 or something. And, when do we tell them they're autistic? How do we tell them? And should we tell them? Will that make them feel different? And as a parent, sitting how do you sit your child? Because no one ever set me down and was like, Treasure, you are cisgender, heteronormative, neuroregular, whatever. You're really in alignment with the standardization nobody, but there's this idea of, and it's across, we see it across many different groups, right? Like I talk about the LGBTQIA plus community, that they have to come out. Like I didn't have to come out and say, well, I'm, hello everyone, I'm
Yeah.
heterosexual, cisgender, right? But for some reason, there's this idea that people who walk differently than us have to reveal them, show yourself and tell us
Yeah.
now what you are. And so there's these conversations that happen where, parents are like, do I you know, I- the we're having these meetings, like you said, about these children, these autistic children. And, then at some point during the IEP process, we bring them in, but at what point and who's the person, like, it's like telling them you're
Yeah.
autistic. But my thing is that the child knows that their brain is, children are very perceptive. They know their brains are different. And how can we get ourselves together in order to empower these people with autism to be self-advocates? Because really, they're always themselves. It's really us getting in the way.
Right. Yeah. And I think, and that's where it's how we talk. Well, one, culturally bound, and how we talk about it. How, like, are we saying it? We're gonna have to sit you down and let you know you're autistic. Like,
Yeah,
how are we presenting it? Like, how that if we have to, it's not a death sentence. We were telling them, yeah, this is just one of the things about yourself. Yeah, and your eyes are blue too, and you're also autistic. And so, how can the world adapt around you? How can we adapt your environment around you so that you feel supported? That's it. Okay. Well, you might.
I
It's
love
okay.
that.
It's loud here. Let's get some
I
headphones.
love
It's
it.
okay.
Water is
You need
wet.
headphones.
Water is red. Your shirt is blue. You're autistic.
Yes.
Yeah, I love it.
Yeah, and Dr. Kristen Botema Butel, she has a great article about using strength-based language.
Okay. I love that,
Mm.
especially as we do our assessments and stuff. And I think it's very difficult, the SLPs, as clinicians in general, when you're in a weakness-based society where, we've been trained again that if I don't speak this way, the child is not going to get services. If I don't
Yes.
speak, people won't hear us. But, it's really trying to balance that. I know I've struggled with it. I'm interested to what your thoughts are about it.
Yes. So the article is called "Avoiding Ableist Language: Suggestions for Autism Researchers," Kristen Botema Butel and et al. At all. But yeah, so it's not to say that, okay, this child is banging their head on the floor, like, great, okay, they're banging their head on the floor. It's like, oh,
Right.
but it's saying, hey, this person, there may be some sensory issues here, or not issues, there may be some sensory differences here that, that we need to explore. And this child may be communicating to us something that we need to understand more. Are they overwhelmed? How can we better understand what's going on here? And again, there was also, who was it? There was a great YouTube video put on by disabilityphilanthropy.org.
Okay.
Disabilityphilanthropy.org. I can put it here. And the interview was with Julie Petty, who is disabled and identifies as a disabled woman. And she was saying that what you call people is how you treat them. And so if we're treating you as this, oh, we're trying to figure out your symptoms, this is a sickness, this is an illness, then we're treating you
Right.
like that. Versus if we're treating you like, these are your characteristics, okay, this is how we're gonna go about this in therapy. This is just a characteristic of who you are. And so
Right.
I'm not asking you to mask, because this is one of your characteristics. We're trying to see how we can better help you to be exactly who you are, but also exist within this world,
Right.
exist within your environment.
And thrive within your environment and have joy in your environment. I love that.
Exactly.
All right, so we have about 6 minutes left. So in our last 6 minutes, I'd like to open it up to the audience to drop questions in for Lillian or for myself into the Q&A, into the webinar chat. I know we have been dropping little gems of articles and of resources that you can take away from this and try out immediately. One thing, as you know, I want to give people a moment to be able to drop their questions in the chat. One thing I always ask at the end of every podcast is, what are you reading, or are there any books, or I'm sure you're in a PhD program, so you're like everything. I don't know the last time you touched a book, maybe it's all articles, but are there any books or articles or readings that you have found that have really inspired you, impacted your practice, impacted you, that you would recommend that listeners throw on their reading list?
So I'm more of I like to I'm more of a visual kind of learner, and so I again that's why I mentioned the disability philanthropy website. I've been looking at a lot of their. I like listening, like hearing the voices of people, and so trying to really understand like the perspectives. And so I've been going to like the autism self advocacy network website to understand a bit more from the self advocate's perspective.
Say it again, autism, and I'm dropping these links in the chat too as we
The
go. So
the
disability philanthropy.
Autism Self Advocacy Network. It's ASAN. It's autism. It's autisticadvocacy.org. I can put it.
Yep.
Okay, great. And then you got the disability philanthropy, and then the color of autism, learning from people from Black and Brown, autistic and neurodivergent people.
Okay. These are so good. I've never heard of these. Okay, I'm
Yeah.
having the color of autism.org. Connecting families to trauma-informed and culturally competent support. Oh, that's so good.
And then the last one is the AWN network, the Autistic Women and Non-Binary Network, which is phenomenal. And they're, again, crossing those lines of all the different intersecting identities and understanding their perspectives. And so I think that, and then, as I'm reading the articles, really just trying to recognize that we need more researchers of color. We need more researchers of color that identify as having a disability or being differently abled,
Mm.
and really trying to learn more and from those individuals and uplifting their voices.
So why? I want you to tell me why, because I think people are just like, oh yeah, but why? Why is it so important to have this?
Yeah, again, try I can have my observation, but we know again there are these biases. I am in an ableist society, and as much as I try, as much as I have, I am conscious that I conscious enough to know and humble enough to know that I don't know it all, and that I know less than somebody that has an actual lived experience.
Yeah.
I cannot, no matter how much research I can read about it, it's like someone that learns a second language. Yes, you are bilingual, but do you understand the culture?
Right,
Are you
right.
understanding the culture? And so there may be things that I am assessing and interpreting that may be off base. And so, and if I'm not collaborating with the community, if I'm not from the community, if I'm not getting insight from individuals in the community, my last study that I just submitted for publication was about Black caregivers of autistic children and children with developmental disabilities. And so I had one on my research team. I had a caregiver, because even though I am a sister of someone that
You're
that
still
is
not,
autistic,
you don't hold that
I'm not a
steady.
Black caregiver of a Black parent of an autistic child and so or adult. And so
Good.
having that perspective is needed in making sure, not just making sure, but having a broader perspective of what we're seeing and how we're interacting with information.
That's so good. That's so good. And you know what? I realized that someone, thank you for the person who said I'm not getting the sites. I had it on.
Oh,
No, that was me. I had it on, we were giving the sites, we were putting it on host and panelists, not giving it to everyone.
Oh, I'm so
I'm going,
sorry.
no, that's what you get for multitasking. So I'm going back through
Right, I
now.
was like throwing all
What do
the
you
other
guys mean
companies.
you're not getting the sites? I'm giving you these. But we were literally putting it in a chat between you and us and not putting it for everyone.
Sorry.
So sorry. You see that those that can't do teach. Yeah, me and Lillian have literally been we've just been throwing all these things in the chat. We're just so sorry, everyone. Thank you for giving us grace.
Okay, good.
So now it's going to everyone. Thank you so much, Candace. And, wow, that's funny. Thank you so much, Yumi. It takes a village. It takes a village, I tell you. Well, I just want to take time to say thank you. All of these years of school, we both knew North.
You know.
That's what my father used to say when I would do something like really silly. He'd be like, all that money for school. Look at you. Look at you. I want to say thank you so much, Lillian. We truly appreciate your research, your education, and the expert view that you've provided about this subject. And thank you everyone for coming. Again, check out Lillian on Instagram and TikTok as the speech scientist. We will see you next month as we talk about cultural humility and mentorship, where we have the Chief Officer for Multicultural Affairs, Dr. Megan Brett Hamilton, on. So thank you so much and have a wonderful night. Thank you so much, Lillian.
Thank you for having me. It's been a pleasure. Bye-bye.
Thank you for joining us for today's course. To complete the course, you must log into your account and complete the quiz and the survey. If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete mailing address in your account profile prior to course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to reflect on your ASHA transcript. Please note that if this information is missing, we cannot submit to ASHA on your behalf. Thanks again for joining us. We hope to see you next time. Each episode comes with an accompanying audio course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code SLPLearn20. Speechtherapypd.com is run by SLPs for SLPs. They've got the largest library of ASHA CE eligible courses out there, and they're adding fresh content every week. Remember, use the code SLPLearn20 to get $20 off access to over 1,000 courses for an entire year. Head over to speechtherapypd.com for more information and start earning CEs today. Thanks for tuning in to the SLP Learning Series. And don't forget, speechtherapypd.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us, and we'd love for you to drop us a quick review and hit that subscribe button.